All right, let's talk about that tightrope we walk every single day. We're trying to manage a patient's massive surgical stress, but the clues we're using, well, they're often late to the party and not very specific. But what if you could actually see that stress, that nociception? What if you could see it in real time as just one objective number? Today, we're taking a really deep dive into the Analgesia Nociception Index, or ANI, a piece of tech that promises to do exactly that. We're going to explore the science, we'll pick apart the evidence, and we'll look at how it's being used right there at the bedside.
Okay, so this really gets to the heart of what we do every single day in the OR, right? Our patients can't talk to us. They're unconscious, often paralyzed. But their bodies are absolutely going through the ringer with the stress of surgery. So the big question is, how do we look past the surface and truly objectively get a handle on their level of nociception?
So to really tackle this, we're going to break it down into 6 parts. We'll kick things off with the problem we all know so well, then we'll get into the physiology behind the solution. After that, we'll critically look at the clinical evidence, see how to use it in practice, and cover the super important limitations before we peek into the future. Okay, let's get into it.
All right, first up, let's talk about the big challenge we're all so familiar with. For as long as any of us can remember, we've been leaning on a couple of vital signs to guide our analgesia. But let's be honest, we all know they're only telling us part of the story.
Okay, first things first, we've got to be really clear on our terms. When our patients are under general anesthesia, we're not actually treating pain. Pain is a conscious experience, it's subjective, it's emotional. What we're managing is nociception. That's the raw, objective, physiological signal of a harmful stimulus, the electrical impulse shooting up the spinal cord that sets off a whole cascade of stress responses. That's our target.
And this is where our old school tools kind of fall short, you know? A high heart rate, a jump in blood pressure. There are classic red flags, sure, but they are so nonspecific. Is it nociception? Is the patient a little light? Are they dry? Is it a drug effect? And on top of all that, they're lagging indicators. By the time that heart rate starts to climb, that whole stress response is already well underway. It puts us in this reactive, subjective spot, which leads to huge differences in how we dose our analgesics. And this table, man, it just lays it all out, doesn't it? The razor's edge we're on. Get it wrong, and there are real consequences. Underdosing isn't just a bumpy ride with vital signs all over the place. It's drenching the patient's body in stress hormones, messing with their immune system, and maybe even setting them up for more post-op pain or even chronic issues. But then you swing the other way. Overdosing on opioids? That's got its own list of problems. Scary hypotension, delayed wake-ups, respiratory depression, and all those miserable side effects we hate to see. It's just crystal clear that we need a better guide.
Okay, so if the usual signs aren't cutting it, where do we look? Well, the answer isn't some new, exotic measurement. It's actually been hiding in plain sight this whole time, right there in the rhythm of the heart, and in our body's own automatic pilot, the autonomic nervous system.
The key, the absolute secret sauce here, is something called heart rate variability, or HRV. Now, this isn't about the heart rate itself, it's about the tiny millisecond-level changes in the time between each heartbeat. And these little fluctuations, they aren't just random noise. They are a direct, measurable window into the constant tug-of-war going on between our sympathetic fight-or-flight system and our parasympathetic rest-and-digest system.
So how does this thing actually work? How do we get from a regular old ECG tracing to a single number we can act on? Well, it's a pretty clever process. It starts with that ECG signal and measures every single R to R interval with incredible precision. But the real magic is in the next step. The algorithm zeroes in on the high-frequency part of that HRV signal, and this is crucial because that specific frequency is almost entirely controlled by the parasympathetic nervous system. So when a surgical stimulus hits, the sympathetic system fires up, and the parasympathetic tone gets pulled back. ANI just measures that withdrawal and turns it into a simple score from 0 to 100.
So it all boils down to this really simple inverse relationship. Think of it like a seesaw. When surgical stress and nociception are high, the sympathetic side of the seesaw goes up, the parasympathetic side goes down, and your ANI score plummets towards 0. But when your analgesia is spot on and the patient is comfortable, the parasympathetic, rest and digest side is in charge. Its activity is high, and the ANI score climbs up towards 100. We're basically measuring the body's level of calm.
And that brings us to the magic number. The number you need to remember, 50. Pretty much all the research points to this number. If your patient's ANI score is 50 or higher, it suggests that the parasympathetic system is in the driver's seat and that nociception is well controlled. A drop below 50, well, that's your alarm bell. That's your signal to act.
telling you the balance is tipping the wrong way.
Okay, let's switch gears and get into the evidence. How does this actually hold up when we put it under the microscope? And, it's important to go into this with open eyes because the story the research tells is, well, it's a little complicated. So this table gives us a great snapshot of some key studies, and a really interesting pattern starts to emerge. When the researchers used real-world surgical stimuli, like in the Jean study with laparoscopy or the Boselli study with laryngoscopy, the results were pretty consistently positive. ANI went down with nociception, and it was able to predict when hemodynamics were about to change. But when they used artificial stimuli, like a tetanic shock, the results got a lot more conflicted. It kind of suggests that ANI is better at tracking the complex stress of a real surgery than just a simple electrical jolt.
And this is what gets really exciting, the predictive power. In study after study, researchers saw the ANI value start to drop several minutes before the heart rate and blood pressure went up. So it's not just telling you what's happening right now, it's like an early warning system. It gives you this window of opportunity to jump in and treat the nociception before it becomes a full-blown hemodynamic mess.
Which leads us to the million-dollar question, right? Does using this thing actually help us use fewer opioids? Can it help us be more precise and maybe dial back our overall consumption during a case? And when you look at the randomized trials, well, it's a split decision. On one hand, you've got studies like Dundar in breast surgery and Legal in bariatric surgery that found the NEI group used significantly less opioid. That's a clear win. But then you have bigger trials like Zental in lap cols and Dostalova in spine surgery, and they found no difference at all compared to just watching the vitals the old-fashioned way.
So to try and make sense of this, let's look at the big meta-analysis from 2023 by Hung and colleagues. They pooled all the data together from 6 different trials with almost 400 patients. And their big, overarching conclusion? When you lump everyone and every surgery type together, using ANI didn't lead to a statistically significant drop in opioid use.
But, and this is a huge but, when they dug deeper into the data, they found something fascinating. They did a subgroup analysis. And in the studies that only included female patients, there was a significant reduction in opioid use with ANI. That effect totally disappeared when they looked at the studies with both men and women. This is a huge clue that gender might be a really important factor here, and maybe the benefits are more pronounced in our female patients. Super interesting stuff.
So what about after the surgery? Does better control in the OR lead to less pain in the PACU? Well, this is where things get even more controversial. Some studies, like one by Upton, found lower pain scores, but others, including that big meta-analysis, found no difference. So why the conflicting results? It could be anything: the type of anesthetics used, how deep the patients were, the different kinds of surgeries. The truth is, the debate is still very much alive on this one.
All right, enough with the studies for a minute. Let's get practical. How do we actually use this thing in the OR? How do we take this number and turn it into real-time decisions that help our patients?
Think of this table as your go-to guide, your clinical playbook. The goal is simple: keep the patient in that green zone, between 50 and 70. That's your sweet spot. If it's creeping up above 70, that suggests pretty deep analgesia. Now, if the patient's stable, that's fine. But if they're also hypotensive, it might be a sign you've overdone it and should think about backing off. The real action point, though, is when it drops below 50. That's your alarm bell. That's your cue to give a bolus, preferably before the surgeon makes their next big move. Now, the monitor gives you 2 numbers, and you got to know the difference. You have your ANI and your AM. Think of it this way. ANI, the instantaneous one, is your radar. It's calculated over just 2 minutes, so it's super reactive. It'll dip fast with something like an intubation. That's your signal for a quick bolus. The AM, the mean value, that's your barometer. It's averaged over 4 minutes, so it's more stable and shows you the overall trend. That's the number you use to tweak your background infusion.
Okay, let's put it all together in a hypothetical case, a standard lap chole. Watch how this plays out. After induction, our barometer, the ANM, is sitting pretty around 65. Then, with intubation, our radar, the ANI, takes a sharp dive to 40. That's our cue. We give a bolus of fentanyl and it pops right back up. Then, with the incision, we see another little dip in the ANI, so we give another bolus. Now, during insufflation, that sustained stimulus, we see our barometer, the ANM, start to drift down. That tells us our baseline rate is too low, so we bump up the remifentanil. It's just a beautiful example of how you use both numbers together.
Okay, super important section here. No monitor is perfect, and you absolutely have to know when ANI isn't reliable, or when you just shouldn't use it at all.
The bottom line is this: ANI is listening to the heart's rhythm.
So anything that messes with that rhythm is going to mess with the number. We're talking absolute no-goes like patients with pacemakers. They don't have their own RR intervals for the machine to analyze. Same with AFib. And you have to be really, really careful with drugs. Beta blockers can make the score look artificially high. And anticholinergics like atropine or glyco, they completely wipe out the parasympathetic signal. It's like cutting the wire the monitor is trying to listen to. The number just becomes meaningless.
And I can't stress this enough. This is a tool. It's an amazing new data point, but it does not replace you. It doesn't replace your brain or your clinical judgment. You have to take that number and put it in the context of everything else that's going on. The hemodynamics, the anesthetic depth, what the surgeon is doing, and your own experience.
All right, so we've gone through the science, the evidence, the nuts and bolts. So what's the verdict? What are the big takeaways that we can bring back to our practice tomorrow?
So, to boil it all down, here are 5 key things. 1. Use your barometer, the ANI, to keep your patient in that 50 to 70 sweet spot. 2. Use your radar, the ANI, to act preemptively when it drops below 50. 3. Keep patient factors in mind, especially that stronger evidence we're seeing in female patients. 4. Know the limitations. Know when you can't trust the number. And finally, number 5. Integrate, don't isolate. Use ANI as one more piece of the puzzle to build a complete picture of your patient.
And I'll leave you with this question to think about. The evidence for ANI is still growing. And yeah, there are some conflicts. But the goal behind it, this whole quest for an objective, real-time number for something that's always been invisible, that's a huge step forward. It forces us to ask bigger questions. How can we make anesthesia more personal? How can we better titrate these incredibly powerful drugs we use? And ultimately, what does a truly successful anesthetic even look like? The journey to finally see and measure nociception, well, it's changing the future of what we do.